Dear colleagues, I'm very, very happy and honored to welcome Professor Iacopo Olivotto here in Zurich. He's from Florence, and he's one of the internationally renowned cardiomyopathy and HCM experts. He has done a lot of research in hypertrophic cardiomyopathy and was also mainly involved in all those clinical mavacamten trials. And he will tell us about the innovative therapies in hypertrophic cardiomyopathy. And I'm looking very much forward to your presentation.
Thank you, Christiane. Thank you so much. It's a real privilege and honor to be here. And these are my disclosures. Well, let me start by saying that cardiomyopathies are more ancient than we think. Cardiomyopathies is an important word. The word was coined by John Goodwin in the late 50s because there was not a word to indicate primary myocardial diseases. So the addition of three letters, cardiomyopathies, really made a whole lot of difference because until we had a name, we didn't really know what we had to face in terms of class of diseases. And for many years, cardiomyopathies have remained like a sort of a Cinderella in the corner of major cardiology meetings. Now, cardiomyopathies are coming to center stage, and more people are getting into research there because the new paradigms for treatment are really, in large part, coming from primary myocardial diseases. It's a sort of a paradox. The cardiologists spend so much time worrying about the coronary disease, the valves, the hypertension, and they focus for many years so little on heart muscle and genetic heart muscle disease in particular. But if you want to trace the origin of cardiomyopathies, I was in the Czech Republic in Brno, and I had the chance to visit Gregory Mendel's Abbey, where he did his genetic experiments with peas, as you know, and he developed modern genetics there. So he was a very clever man. He was clever in many fields, but he tried to get into academia. And he, at the time, was in the Austro-Hungarian Empire. So he went to Vienna to study and unfortunately didn't make it to academia because he failed the exams. But if you see here, this is his report from it was actually exhibited in the museum. You see, this is Gregory Mendel, and you see that the only subject where he got top marks was physics, and his teacher was Christian Doppler. So genetics and ultrasounds, as you see, were already joining together forces in the time. So my personal history is much more humble. I studied not as old as this, but this is where actually cardiology started in Florence, very ugly looking building. And in the 70s, Franco Cecchi was my mentor, assembled the first 10 cases of hypertrophic cardiomyopathies, and this was his thesis. And he developed, for his whole life, developed the theme and then set up the first cardiomyopathy center in Florence. And at the time, we had CMA is not cardiomyosin inhibitors. Now this means cardiomyosin inhibitors, but at the time in Italy, this is cardiomyopathy hypertrophica. So this is, many of these patients we're still following now. So we are now following patients we have seen for 30 years, 40 years, and we know the families, we know a lot of the histories from the beginning to end of these patients. In the 90s, the mid-90s, when I was a young fellow, I was fortunate enough to start working with Barry Meron, and we would write two papers together. Every paper took several drafts and many months, but they came out to be really nicely written, thanks to Barry, of course. This was our first paper there. At the time, and for many years, hypertrophic cardiomyopathy was a matter of sudden cardiac death. So who is the patient that is at risk? Even before we had a defibrillator, this was the main focus. And of course, obstruction. And so how do you treat obstruction? There were endless debates about surgery versus alcohol ablation, which is better, which is worse, very heated debates. So the focus really was only on these two aspects. And of course, obstruction is very striking. Systolic anterior movement of the mitral valve, hypertrophy. This is really what catches the eye and what characterizes the disease. So for a long time, the myectomy, for example, was a gold standard. And indeed, it is quite rewarding to have a patient that can be operated. And after operation, this was performed by Meyer in Florence. You can see that the same patient as the previous figure now has no obstruction. The coaptation of the mitral valve is perfect. Look at how nice the myectomy is here and how normal the coaptation of the mitral valve now looks. And this girl was really happy, +1 for many years. But of course, this is a disease of the myocardium. So what we have now began to appreciate after many years of following the patient, and this is a cardiomyopathic disease with a regressive sort of aspect that will lead to progressive fibrosis and dysfunction, that this girl is now listed for transplant. And of course, sometimes we have children, very young children that have massive phenotypes, and you can see that definitely obstruction is part of this, but this is not really what strikes me. It's the muscle, isn't it? It's even newborns. This is an 11-month baby with clear hypertrophic cardiomyopathy and family history, and it's all about the muscle. So this is really where we have to concentrate. This is how we attempted to sort of stage the disease at the time with Mike Iacopo and Franco, and so there's definitely a part of the patients present even before they have hypertrophy, but the only way to catch those is to have genetic testing. We only see this in the context of families. We all have genotype. Most of these patients then have sort of ups and downs, but maybe have obstruction, may have AFib, may have arrhythmias, may have some dyspnea, some angina, but overall have a very steady course with no major events. But there's 15 to 20% would definitely go into what I call the catabolic phase. So the anabolic phase is when you build up your muscle, and then catabolic is when the muscle goes into regression, maladaptation and regression. And so the way I picture myself, the disease now is a little bit like Napoleon trying to conquer Russia, okay? So he started with an overambitious plan. He had the greatest army ever. He said, this is going to be really big. So hypertrophic ego. And then the winter sets in. So ischemia, inflammation, energy proliferation, mitochondrial dysfunction. And then, of course, we go into the winter. And this is what winter looks like in hypertrophic cardiomyopathy. So you may have the hypokinetic sort of the dilated, so to say. It's never really dilated, but it's hypokinetic model. This is an unfortunate child with 2 alleles with protein C mutation. So it's it's a virtually homozygous disease here, very severe case. And this is a restrictive, so more typical of troponin disease, the restrictive phenotype. It's still HCM, still hypertrophic cardiomyopathy, but you can see the progression of fibrosis building up. And this is what happens sometimes in the most unfortunate patients. This is not the rule, but it can be very aggressive, and some degree of progression of maladaptation, of course, is the rule for everyone. When you transplant a patient with hypertrophic cardiomyopathy, almost 40% of the myocardium is replaced by fibrosis. It's one of the most fibrosing sort of diseases of the heart you can imagine. So what happens at the myocardial level? Well, we try to do this, to look at this in several ways. We're fortunate in Florence to have a very good set of basic lab for physiology and pharmacology, and our scientists look at isolated cells with patch clamping techniques, and they also look at trabecular and contraction and relaxation. So several years ago now, more than 10 years ago now, we looked specifically at the action potentials of human HCM cardiomyocytes taken from myectomy samples. And the thing that was quite obvious at the time was that action potential is severely prolonged in these individuals, very severely prolonged due to overactivation of the late sodium current. This is a mechanism of sort of maladaptation that's common to coronary disease, to heart failure in general, but here it's really quite striking. And the action potential prolongation is associated with marked presence of delayed and early afterrepolarizations, which are a marker of electrical instability of the cell, and they're nicely correlated to the presence of non-sustained VT in vivo. So it's a sort of surrogate of arrhythmogenicity in vitro. And keep this in mind because I'll come to this in a minute. So, and this is quite obvious because this is a mechanical disease due to sarcomere mutations. As you know, HCM is a disease of the sarcomere. The genes that cause HCM are sarcomeric genes, especially beta-myosin, myosin-binding protein C, but also troponins and others. But of course, the sarcomere is so near to the sarcolemma, is so near to all the other apparatuses in the cells, and particularly the ion channels on the membrane. So it's really naive to think you can have such a profound mechanical disease without having an acquired channelopathy of some kind. We know this to be the case also for ARVC, for example, affecting the sodium channels. Here, it's mostly late sodium channel overactivation. And this is relevant because if you consider arrhythmic propensity in these patients, everybody is now focusing on fibrosis. LGE is the crucial thing. The more LGE you have, the more sudden death, the more arrhythmias. Well, 50% of our patients have LGE. 50% have some kind of fibrosis. Sometimes it's quite substantial, but only a minority have arrhythmias, particularly life-threatening arrhythmias. So how do you explain that? And think about it. Re-entry arrhythmias are not so common. You don't really send HCM patient to ablation very often, do you? While you would send other kinds of cardiomyopathies to the electrophysiologist for ablation, you don't really send HCM patient for ablation simply because there are no sort of fixed re-entry pattern apart from apical aneurysms. Otherwise, it's usually quite polymorphic. It's not predictable, not easy to interrupt these circuits. And this is because you need a combination of two agents. You need fibrosis, but you also need electrical instability to have arrhythmias in these patients. This is an experience we're now in the process of submitting. So looking again at our approximately 100 patients with myectomies we have studied in vitro, and looking at their MRIs, you can see here on the right, if you have fibrosis here, if you have LG, but no delayed after depolarizations, you have no arrhythmias in vivo, nothing. The Holter is clean, no sustained VT, nothing, no signal. If you have a combination of fibrosis and LG, that's the patient that is at risk and will have a risk. So, and this explains also why we have quite good results with, for example, class 1 CRF arrhythmics in these patients to control these arrhythmias rather better than Sotalol, for example, because it's probably the cellular trigger that's really focal to arrhythmia rather than just the reentry per se. So keep in mind, it's not so easy and the real challenge now is to understand how can we identify in vivo in the patient the surrogate of electrical instability. That's not easy to do. Of course, we can't take myocardial samples in everyone to check for that. So we also, of course, at that time thought, well, we have a perfect inhibitor for late sudden current, which is ranolazine. It's used, it's safe, it's been around forever. Let's use it. And in vitro, it remarkably corrected all the major problems here. So the action potential was shortened and the electrical instability went away very nicely. And by the way, disopyramide, which we also characterized in vitro quite extensively, does pretty much the same. It does a lot of nice things, acts on a number of channels, but also, as you see here in the bottom here, I'm sorry, it's a little small, it does reduce the action potential and gets rid of the after depolarization, which also accounts why the drug is so safe in this disease, even though we're so scared to use class 1C in a cardiomyopathy such as ACM. In fact, the drug is quite safe, and the signals in general registries is that it actually protects from rather than promotes arrhythmias. But again, so at that time, and we are talking about 15 years ago, we started concentrating on the possible use in vivo of ranolazine here, because with one single target, so late sodium current, you could potentially address different targets. So arrhythmias, diastolic dysfunction, because if you reduce the number of the amount of sodium, but it's really calcium, isn't it? The phase, so the late sodium channel is what really triggers the entry of the calcium in the cell and explains why HCM cells are so full of calcium. So getting rid of that by shortening action potential and blocking the late sodium could get rid of the diastolic dysfunction, the ischemia, and the arrhythmias with only in one go. So that was very nicely in concept the way to do this. So at the time we designed what is probably the first international randomized double-blind placebo-controlled trial in HCM. It was really pioneering work, even though it's not so old. This was published in 2018, so it's not really that old. At the time, we designed this little trial. It's only 88 patients to see whether ranolazine could improve functional capacity. Peak VO2 was the primary endpoint because really that's what we could do at the time. We thought it was a smart thing to do. Non-obstructive patients, we didn't want obstruction to interfere with functional capacity. That was too much of a bias. And the trial was negative, so we couldn't show any benefit. But in terms of peak VO2, but we did see a signal in terms of reduction of ventricular ectopics on the Holter, and the drug proved to be very safe. And importantly, we showed the world that trials could be done in this disease, because before that, there was only very few scattered experiences in very small number of patients. So this was like a first that sort of set the way for future trials. Also, we had very striking individual responders to ranolazine. Young persons had repeated ICD shocks, cardiac arrests, usually preceded by chest pain, so clearly in some way triggered by ischemia, particularly with troponin disease. Some of them were so striking responders that they stopped having any event after ranolazine, and the symptoms went away. So this seemed like a very promising field for future investigation. Gilead, who owned ranolazine, decided to invest and to produce a super late sodium channel blocker called aleclazine, which was much more powerful and selective. We designed a larger trial, huge number of centers, not such a huge number of patients, because it was around 200 patients planned. As you see here, almost more centers than patients in this trial. But we had the logo, we had all the nice sort of gadgetry of trials for the first time, steering committee, boards. And so really felt like there was a change in the way. And then, of course, the drug was aborted because the parallel trial in ICD carers had an excess of arrhythmic events. So overnight, the trial was aborted and the drug was aborted. And that was the end of aleclazine. But again, new emphasis and maybe sort of the feeling that this could be done. And this brought about new problems for us, because we, for the first time, realized that the cardiomyopathy community was not ready for trials. We didn't have trial teams. We didn't have endpoints. How do you assess a benefit in a disease that is slowly progressing with a mortality of roughly less than 1% per year, little hospitalizations? This is not the 70-year-old heart failure guy. This is usually a 45-year-old patient with symptoms, but otherwise quite stable. So we came up with a lot of hard thinking, and the process is still ongoing. We're still in the early days now of trial design in this disease. And this really sort of triggered all our community to think about setting up trial units. And we'll still have a long way to go, but things have moved quite quickly. So this leads us now to what has really happened now in terms of the little revolution that is happening now, which is myosin modulators. I like this word better because it's a family that can do both things, either promote or inhibit. And of course, the idea for myosin modulation, which is, if you think, is almost obvious once you know it, because what best than modulating myosin in a motor like a heart? It's an obvious target for treatment. It's tough because, of course, when we started, well, I wish it was me, but when they started, so when our scientists started thinking about this in the States particularly, of course, they went for the hypokinetic delete model, because this is what we are most scared about. So we're scared about, that's not. It's all searching, it's more relaxed. Okay. So we are trained to think about loss of contraction, okay? We are worried if we see somebody with a 30% ejection fraction or even a 40% ejection fraction. We don't care if somebody has a 75 or 80% ejection fraction. We don't mind. That we don't mind. We've never given any thought to that. So the first drug that came about, it was actually a myosin stimulator, omecamtiv. As you know, it's been quite an unfortunate drug. We can talk about it in discussion, but it's a very interesting drug because it's probably the first clean inotrope that doesn't increase mortality and has led to an advantage in terms of reduced hospitalization in heart failure trial in a large trial. But of course, from our perspective, HCM specialists, what really came as a novelty was possibility of myosin inhibition. This comes from the work of James Purich in Stanford and others, the Seidmans and Leslie Langwand, who came up with the concept that, in fact, hypertrophic cardiomyopathy is not solely or not mainly a disease of hypertrophy. It is a disease of hypercontractility. This is a disease where you have too much of a good thing. So myosins are sort of change their conformation due to genetic sort of abnormalities, either in the molecule per se or in surrounding genes that ultimately lead to hyperactivation of the myosin, which is really pretty much the same as an end result. So that if you can sort of modulate, down titrate the action of the drug of the myosin, which is an enzyme after all, this is beneficial to patients. And of course, to understand why this is, you have to remind that myosin is really very heavily regulated in nature, in evolution. It's one of the most heavily regulated sort of molecules in the body, probably. And there's actually three different energetic states of myosin in the heart. So that you have an activated state, you have a sort of semi-activated sort of DRX, and then you have this thing called super relaxed state, which is when the dimers are folded and closed down and now have virtually zero ATP consumption. And this is the state, for example, that's highly prevailing in hibernating animals. But it's also prevailing in humans and in animals in general. If you see the proportion here, only 10% of your cardiac myosin is active at any given time. So 90% of your actin of your myosin, is either in a semi-active or a completely inactive state. And this is really important because HCM mutation, as I told you before, is shifting the balance towards high energy consumption states, higher activation states. More myosin heads are activated at any given time. So if you forget about hypertrophy for a minute and think about what goes on inside these hearts, because we've been so focused on measuring hypertrophy and thinking about hypertrophy, think about function here. This is a case with midventricular obstruction. And it's quite obvious if you then see the patients, and I will show you clips later, that this is also a disease of hypercontractility. Hypertrophy is probably a maladaptation to that. So why is it bad to have too much contraction? Again, this is not intuitive for a cardiologist. The problem is that anything that increases your contraction worsens your relaxation, increasing your calcium sensitivity and your tension cost. So you have a hard time relaxing, and your consumption, it's like a little bit of a tetanic state, which will increase your energy consumption, irrespective of the genotype, and of course, ultimately lead to bad consequences because of energy propagation, mitochondrial dysfunction, and ultimately fibrosis, probably inflammation, as we were discussing previously with Professor Rushinsky. Keep in mind that also in the general population, there's now consistent data that hypercontractility is bad. So there's a J shape, particularly if you have a low stroke volume index. It's not good for you to have a very high ejection fraction for whatever reason in the general population. So it's a general concept. In HCM, it's monogenic. In the general population, it's polygenic. It's still genetically regulated, but it's not good for you to be hypercontractile and to have a small ventricle, which is exactly what HCM patients have. So what does mavacamten do and what does aficamten do? It's virtually a small molecule that is orally available, binds to the myosin, and virtually, as you see here, just reduces contractility. There's no sealing effect. So if you give too much of it, the heart will actually come to a stop. So it's important to keep in sort of safety margin, but if used correctly, as we have done in trials, it's proven to be quite safe. So ultimately, your Lamborghini, which is unaffordable, nice but unaffordable, at least to Italians, I don't know, probably here it's different, but becomes a diesel truck. And this is really what you want. You want to have these sort of HCM hearts want really to look more like a diesel, less exciting, but more sustainable, more durable. And so, of course, this is a success story. Things don't always work out that way. As you know, developing drug costs hundreds of millions and takes 10 years, and 99% of the drugs that are initially sort of planned don't really end up coming to the market. This was a success story because the drug did exactly what was planned to do. So it reduces the number of myosin heads in contraction. There's very solid preclinical data showing in the mice, but also in pigs and dogs, showing hemodynamic benefit, but also suppression of, for example, pro-fibrotic genes and a number of other positive sort of structural and functional improvement, including energy sort of sparing. In clinical trial, the drugs, both aficamten and mavacamten, of course, was the first drug, which were initially explored in patients with obstructive HCM. Why? Well, there was consideration of doing all comers, but of course, obstruction is a nice target. We know obstruction causes symptoms. We know if you remove obstruction, you will be better. There's 50 years experience on surgery with that. So this was an obvious target to start, sort of lower hanging fruit. Non-obstructive disease, studies are ongoing. much harder to show a benefit because, of course, when you're dealing with diastolic dysfunction and measuring the benefits of that, as you know, it's always tougher. HFpEF trials have taught us about this. So the drug has now been approved both in probably FDA, the European community. It's already available here in Switzerland, and we are still on compassionate use in Italy. As you know, the drug is ready in the guidelines for obstructive disease. We're talking only about obstructive patients, and hopefully there will be an upgrade from class 2A to class 1 as more data come up. Sequoia, which is the trial with aficamten in obstructive disease, so it's equivalent to the Explorer trial, will be presented in Lisbon at the HFA. And we already know from the top line result that it's a successful trial as well. So there will soon be another agent available. This is data from the main data from Explorer, which is the phase 3 trial which led to registration. 251 patients treated, obstructive symptomatic patients treated for 32 weeks. And you can see here the reduction in exercise gradient, very mild compared to placebo, with only a small drop in ejection fraction. So very nice hemodynamic effect, small reduction in function. But I will show you that this is not the whole story. The reduction in ejection fraction is only part of the story. The effect is very consistent across all the subset. But of course, if you reduce contractility, you will have benefit in terms of obstruction, no matter what. But what's really important is quality of life improvement is quite striking, almost surgical sort of improvement. And the reduction in biomarkers, which of course is really what you want to see. You want to see how deeply you are affecting your heart function and the stress and the cell death, which is really what you're seeing here. But let's look at the effect of the drug. This is really what's striking. Look at the baseline. This is one patient from Florence. You can see now that how we have not paid attention to this, but this is really hypercontracted. Look at the apex of this heart on the left. It's really that the heart is almost unable to relax and completely obliterates in systole. Look at the right ventricle. Look at the same ventricle after 32 weeks of treatment with mavacamten. The heart looks a lot more normal, not only because the contraction is less frantic. Look at the morphology. Look at the morphology of the apex. Look at the volume here. And there's consistent data showing that this remodeling goes on for about several months. And so the stroke volume looks better. The heart looks less hypertrophic. There is a loss in thickness. That's not due to loss in cardiac mass. There may be some, but it's still under scrutiny. But it's definitely because these hearts have never been end diastolic in their lives. This is the first time that this ventricle is really, truly end diastolic. So this is quite amazing. It's like somebody who can finally stretch after having been sort of contracting for years. It's quite amazing. And to see what patients feel like, it's equally amazing. So this is the gradients going down, both on resting condition and with Valsalva. Diastolic function improving quite strikingly from a pseudo-normal pattern to sort of much more normal looking pattern here. Of course, there will be patients occasionally, like this one we had in Florence, who had too much, responded too much, so developed dysfunction, came back due to fatigue, and his ejection fraction had dropped from 73 to 40%. Sorry, maybe the clip is not moving now. Let me see if I can get it to move again. Okay, sorry about that. And after washing out the drug, the patient goes back to having a very normal looking ventricle, full benefit. I don't have time to get into the details, but also looking at deformation, the heart becomes a lot more synchronous. So looking at electrical and mechanical dispersion. So if you look at, this is peak systolic dispersion, and this on the right is QT dispersion on the ECG. They improve quite dramatically. And also the bonus we were not expecting is, look at this, electrical remodeling. Remember about the ion channels, remember about the late sodium current, all the sort of the electrophysiological maladaptation I was telling you about. This is probably what's going on here. These cells are gradually improving their sort of channel distribution, the channel function on the sarcolemma. This is not hemodynamic. This is probably really electrophysiological. If you take the drug away, everything goes back to previous state. So everything goes back to where it was. So it's really literally transient and due to the drug. If you feed these ECGs to an artificial intelligence sort of system. Two of these actually. Most of these systems can pick up HCM at the beginning of the trials. At the end of the trial, ECG, the system doesn't recognize HCM anymore, because a lot of these ECGs have normalized or improved quite dramatically. So just to say that improving sarcomere will improve electrophysiological, and possibly this is, we still don't know, this is the holy grail, possibly reduce your risk of cardiac death and arrhythmias. This is really what we would like to see, and indirect antiarrhythmic effect. We're hoping to see that. We still don't have that data. Of course, as you know, we had another trial called VALOR HCM, which was performed looking at surgical eligibility. 100% of these patients with obstructive disease were eligible for a myectomy at the entry of the study, and only 9% of the patients were still eligible at the end of the study. So clearly, these patients who are responding well, and most patients respond well, will not be candidates for surgery anymore. Does this mean we're not operating surgery patients anymore? No, I think it just means that we will only have to operate the patients that have some additional problems, such as organic mitral valve or geometrical problem, or who will not respond to the drug. Otherwise, it is expectable that the number of procedures here will be reduced by long-term use of these agents. But again, let's not focus too much on obstruction, and remember that we are wanting to treat the muscle. And this is, again, animal data from mavacamten. And the final proof for us will be to see what happens in non-obstructive disease. Hopefully, maybe in the future, extending also to subset of HFpEF as well. But focusing on non-obstructive disease, we have data. This is aficamten. This is data from Redwood. So the phase 2 study, the non-obstructive cohort from Redwood, you can see here, non-obstructive disease, symptomatic patient with diastolic dysfunction, improvement in clinical symptoms, improvement in angina, and again, improvement in cardiac biomarkers. 2 large studies are on the way, Odyssey for mavacamten, Acacia for aficamten, and hopefully in a couple of years, we will find out. So really, we are now entering an era where the cardiologist has to learn to act on yet another system. We've learned to modulate adrenergic system, the RAS system, the coagulation cascade. With COVID, we also had to learn to modulate the immune system. And now we will probably have to learn to use the sarcomere modulators in the future, more and more so in a targeted way. And this is really quite exciting to me. While in the meantime, look at the explosion in trials for, this is just for hypertrophic cardiomyopathy. So not taking into account other cardiomyopathies. Thus, in a span of 10 years, look at the number of experimentations ongoing compared to only 10 years ago when there was nothing going on. Just single word to say that there are also gene therapies which are coming our way. Most promising is now for Fabry disease and for Danon disease, which are, Florence will hopefully start Danon disease gene therapy soon in children, in adolescents, males with the disease. There are a number of challenges we're happy to discuss, although, again, nobody really has answers to many of these questions, but there are there are at least 4 or 5 initiatives aimed at specific structural cardiomyopathies, which are obviously much more difficult to target. It's easier to target a storage disease than a cardiomyopathy for a number of reasons, but it's coming our way. So there are a number of genes that will soon be possibly actionable by these treatments, and for the most severe patients, maybe the only option. So in conclusion, I think we really are on the verge of a mini revolution. We have just started at this new sort of part of the story of cardiomyopathies, finding precision treatments, which hopefully will also extend to other conditions. If we identify targets here, pretty much like in oncology, you may then use the same target for other conditions and then benefit a much larger number of patients. But even just concentrating on cardiomyopathies, I think, is not negligible in terms of epidemiological and conceptual importance of these diseases. Let me just conclude by thanking the people who have done the work in the lab in Florence: Corrado Poggesi, Raffaele Puppini, Cecilia Ferrantini, Elisabetta Cerbai, Francesca Girolami, who is our senior geneticist. This is the team at the Pediatric Hospital and Careggi. Thank you very much for your attention.
Iacopo, many thanks for this great talk and insights into one of my favorite topics in cardiology, and also the difficulties we have and we face in more or less rare diseases. And first, I'd like to open the questions to the audience, because I have many questions afterwards I can ask.
I do it.
We also have participants on Zoom, but to be honest, I don't know if they would. I think.
Why don't we kick off?
Okay, so we've already briefly discussed it, what we do with patients that want to become pregnant, that are on mavacamten, or maybe that are on mavacamten and have to undergo major surgery, not cardiac surgery, because now we have those patients on those drugs and life goes on and they develop other diseases that or conditions we need to take care of. How do we handle that?
Yeah, so there are a number of practical points. The drug, again, has been shown to be very safe. There are a number of patients who develop some degree of systolic dysfunction over time, sometimes precipitated by atrial fibrillation, sometimes for reasons we still don't know. So you have to check these patients. Right now, you have a risk mitigation plan that in most countries implies checking an echo every 3 months, which is quite challenging, but hopefully with time we will get more confident. And so the drug is metabolized by CYP219 and other cytochrome, pretty much like clopidogrel, but it's the opposite way. So clopidogrel is activated by the cytochrome, and this drug is inactivated. So if you have a slow metabolizer, you may have increased levels and then high risk of dysfunction. This is why in Europe, for example, we have to genotype the patient for the cytochromes and identify slow metabolizers. But in Caucasian population, it's only like 2 to 3%. It's more in Asian population that you have to worry. Otherwise, it's also quite safe there as well, provided you keep lower dose to start. The drug is teratogenic in animals, so it should not be used in pregnancy. So that is an issue for us because we're now starting to use the drug, and of course we have a lot of younger sort of female patients that have obstruction and want to have a pregnancy, and so but I don't think it's a good idea to start the drug and then stop the drug just before pregnancy. So you go into pregnancy with the rebound of obstruction, because it does come back, and it's not nice. So in that case, probably you still would have to go for surgery before planning a pregnancy. If again, don't forget that many patients with mild degrees of obstruction tolerate pregnancy quite well. So it's only for these severely symptomatic cases that you should really do that. Otherwise, the drug is quite compatible with everyday life. It's a slow-acting drug. Aficamten is quicker, but it still takes about sort of 6 weeks to titrate. Mavacamten can take to 3 months to titrate. So even if you wash it out, it takes a while. If you run into trouble, including severe systolic dysfunction for any reason, overdose, whatever, intoxication, there's good in vitro studies showing that you can salvage activating the remaining myosin heads with basically based on energetic agents. You can actually salvage these hearts. So they respond to general classic inotropes. But of course, that is an issue. We still don't have enough safety data to say for sure on thousands of patients, how safe the drug is on larger numbers. And we have treated now patients for up to 3 years, and the effect is quite well sustained, and the safety is also sustained. The ejection fraction stays quite stable once the trough has been reached.
It's very impressive, the remodeling of this ventricle you showed us after 3 years. Do you think about reducing the dosage when they have remodeled, or you keep the initial dosage, you titrate them up too?
That's a very good question. No, right now the concept is you push the dose up. This is particularly relevant to non-obstructive disease when the time will come. So you push the dose. It's usually between 5 and 10 milligrams. You can go up to 15, or you can go down to 2.5 in the slow metabolizer. But it's usually, most patients will be between 5 and 10. And provided the gradient is reduced nicely, if the ejection fraction remains quite comfortably high, there's no reason to really come down, because don't forget, we're not treating obstruction. So we're treating the muscle. So we want to really normalize the energetic sort of mishandling that is ongoing and the excessive sarcomere activation. So there's no, like you would not sort of down titrate Entresto, or you think likewise I would not do this here.
Habt ihr Fragen? Erstmal zuerst ihr, bevor wir fragen.
Thank you for this great, excellent talk. To be honest, I have no experience with this medicine at all, but I'm wondering, does it have some influence of some other muscle in our body?
Excellent question. Yes, so our physiologists have studied the drug also on soleal muscle, so it does affect the skeletal muscle, but it's very specific. So in order to have some effect in skeletal muscle, you have to increase concentration more than 10-fold. So, but with the doses we use in clinic, there is no report, and even in experimental animals, skeletal muscle is not affected. It would be if you increase the dose 10-fold, but then your heart would probably stop. Yes.
Thank you very much for the lecture. It was
my question is regarding the atrial fibrillation events in the trials. Do you think they are just an expression of HCM progression? Because they were
on the placebo group. And if you do Holter follow-ups in patients on mavacamten at any follow-up point. And on the other hand, the other question was if during the follow-up, as the endpoint was the CATP, stress ergometry, if you do it in your center, follow-up with that or not, or is it just like follow-up with TTE and adjusting, titrating the dose depending on the LVOT gradient? Thank you.
Thank you for two very nice questions. So atrial fibrillation, we did not see a signal showing excess atrial fibrillation. There has been a hint that, purely hypothetical, really saying that because you're reducing contraction at the atrium, you may be more exposed to atrial fibrillation in these patients over time because of that. But in fact, in obstructive disease, the reducing left atrial stress by reducing obstruction and MR is definitely giving an advantage to these hearts, to these ventricle. So in this atrial, so for example, in Explorer, atrial fibrillation was in fact, if anything, a little less prevalent in the treatment arm, not significant, but we had not seen that signal. It is one of those things we should look about because, of course, theoretically, you are reducing atrial contraction. So it may be that in some patients you may observe greater. So we still, we have to monitor them anyway for atrial fibrillation because that's such a common occurrence, particularly in obstructive disease. So in terms of follow-up, well, no, we don't do CPAT on a routinely basis because it's really, time-consuming. You may want to do it for research purposes. I would expect patients to continue improving because their muscle gets better, they get more conditioning, they do a lot more, they train more. But in terms of the long-term follow-up, just reduce just echo and the Holter and the visit as a routine.
Thank you very much for the very impressive presentation, and all the results are really, I think, a step forward in cardiology. I have two questions, and because some of the patients, as you showed us, had increased ejection fraction, which you covered. Do you then continue with the same dose, or do you modulate the dose, or do we decrease the dose in those patients? And the other question, as we see remodeling processes during this time, which could be more associated with arrhythmic potential, did you see any arrhythmic potential in those patients with in reduced ejection fraction? Were there more events, or didn't you see any arrhythmic potential at all?
Well, thank you. Start with the last one. No, we did not see because the effect is strange. So if you have reduced ejection fraction and you stop the drug, ejection fraction goes back to normal within a couple of weeks. and even shorter term with aficamten. So, there was really no time to observe any effect. And the first question, sorry, was, apologies.
As we saw, some of the patients had an ejection fraction which was lower than 50% in some cases. And then do you modulate the doses? Do you reduce the doses, or do you continue with the same doses? And is this more because what you already heard, that there are some fast metabolisms and some slower? Is this a effect of the metabolism of the patient? Is an individual thing we can monitor, or how do you?
So if you have ejection fraction below 50%, you with mavacamten, you're supposed to stop the drug for 4 weeks and then wash out and start at the lower dose. If you are already on the lowest dose, you are entitled to try once more with the 2.5. And if you have twice below 50%, then you have to discontinue the drug permanently. With aficamten, for example, in Sequoia, the protocol was different. So there was a dose reduction with no washout. So ideally, you don't have to wash out in that case. Just reduce the drug, because it's a faster half-life, so it's washed away quicker, and see how it does. So my practical advice is that you keep about sort of 60 to 65 threshold in your patient. So even if you have somebody who drops from 75 to 55, I wouldn't be so happy. I would sort of reduce the dose as a preventive measure anyway, because patients would be incredibly well even with higher levels. So I would keep away from the 50 quite well away. Remember that in HCM, anything below 65 is already quite low for HCM. So I would keep on a safety sort of level.
More questions? All the questions came, that's like in your department, in our department from the women. All of them. We all were proud that we are, half of our clinic is, we are very gender sensitive, is run by our bosses.
Yes, like we are.
Exactly, that's what I thought. Maybe I have a few questions. First of all, I would like to say something. It's what a wonderful talk, and what a wonderful achievement. I think everybody should please understand that this is changing cardiology. It has changed it. And what a wonderful word also say, well, listen, this is evolution of knowledge and a revolution in management. We had alcohol, septal, in all the surgery. Our surgeon came, that's why I was waiting. It wasn't better that he came. This was amazing at the time. But to see that now being treated with a drug, that is nothing but spectacular. And I think this is huge. And that's also, and very happy for you because this is your life journey,
Yes, absolutely. I was very fortunate.
Nothing really wrong with that. And when you have a young fellow like Eugene Braunwald being your first author on the paper, what could be better than that? But here's one, this is great. And I think everyone should achieve that, because we are the coronary clinic, because Grunzig did it here first. But at the end, this organ is a muscle. We all love about, and you modulate that. And we are from the heart failure cardiomyopathy world. We think, well, the coronaries are important, but the muscle is actually what it is about. Here's my question. I followed a lot omecamtiv. I'm a heart failure kind of guy. And is it fair to say omecamtiv mecarbil is the natural born antagonist of mavacamten? Is that fair?
Yes. The site is pretty much, it's very, very similar. The site of action is actually very similar.
Exactly.
Very near. Yes.
So that's very important, because some of you know omecamtiv mecarbil. We have used it here. And some of what you've learned about omecamtiv, anemia, all of this stuff, that actually is not applying to mavacamten. If it's actually the natural born enemy, be careful with that, because I hear that all the time. Because as you said, the one is a myosin activator, and the other one is somewhat as you say, modulator, right? It's not the same thing. That's one thing. But having said that, you decrease contractility, among other things. Is there a time when it is too late for mavacamten? When should we do that? Because, Christiane and I, we discuss a lot. Sometimes we discuss a lot with patients, or with Andreas, the patient with hypertrophic at the end, hopefully we can treat them early, comes not to transplantation anymore. But then it's probably too late to give a drug that decreases contractility. So when is the sweet spot?
So this is the patient I showed you before, pediatric patient. So the point is we don't know, because when it comes to non-obstructive disease with reduced function, you can see it both ways. You can see, there's already so much fibrosis that it's just a waste. You can't give a negative inotrope because this is going to fail. Or you can say, there's already so much of the heart that is dead. Let's try and save the remaining part. Of course, we are all extremely scared to give this drug to somebody who has already dropped their ejection fraction below anything like 55%. And this is an exclusion criteria for the non-obstructive sort of trials, of course. So we need to be extremely cautious there in that particular setting, because again, usually when you have severe dysfunction here, it's because the heart is so fibrosed. We have instances where this is not necessarily the case. So some of the kids we have severe dysfunction within the presence of mild sort of fibrosis, and these are the hearts you hope to salvage. But on average, I think first of all we have to get the feedback from non-obstructive trials. So if a classic sort of hypercontractile non-obstructive trial will show benefit, then we can move to lower sort of thresholds. Remember that non-obstructive disease is always less contractile than the obstructive disease. So the patient that will be enrolled in Sequoia, in Odyssey and in Acacia probably will have an ejection fraction almost 10 points lower than because you have to be symptomatic, you have to be non-obstructive, you have to have high BNP. So this is the already patients who are on the sort of downhill side of the disease, and these are already dysfunctional patients. So if we get clear good results here, we can be more bold. Right now, we need to stay away from patients who have systolic dysfunction.
We always say heart failure is not a disease, it's a syndrome of hundreds of diseases. We have to deeper phenotype, identify the target, as you did, and have personalized, targeted, individualized therapies, and then we win. I think at the end, we're moving a bit like oncology, where we really better, deeper pheno, geno, immuno, whatever type, understand better, and then treat accordingly. For me, it's really, I was very much looking forward to this talk, and we're really phenomenal that you took us on that ride. Hey guys, you have questions? Certainly you have. Come, this is a question to ask someone who has delivered on his promise over 30 years. This is something different, huh? Not everybody is that lucky or smart or both.
I was very lucky, honestly.
Now we say in football, right? There's a very famous German football coach who says, when you're always lucky, that means you're good.
Well, there were a lot of failures here, you can see here.
I know, that's true. But you delivered that. This changes a lot. Huh? And Andreas just left. He runs our amyloid program. Amyloid, in one day, in a couple of years from now, we'll look back and say, amyloid and hypertrophic paved the way for targeted therapies of the muscle, clear, and the deeper phenotyping approach that we all believe in.
Yes, I agree. We have a huge amyloid clinic in Florence, and that's really a model. It's a little bit less rewarding because any result takes time to see, whereas this is quick. So, but it's incredibly challenging, and some of the ideas behind these new drugs are just amazing. So just by observing a single mutation, the effect of single mutation, you develop a drug that will, so it's really mind-boggling to see how much brilliance there is behind this research.
And one thing, 55 ejection fraction below is high 55, 55, that you have below, you would be careful, right?
Yeah, so I would say in the same way, I often ask, what do you do when you have obstruction in Fabry disease or obstruction in Noonan disease, and you need to stay away as well, because we don't really know what happens outside the context of sarcomere disease. So hopefully in the future, for example, myosin inhibitors may have a prospect for other conditions, including, maladaptation to hypertension or renal disease. Some of these patients with severe diastolic dysfunction, we see that have flushing pulmonary edema in the context of, for example, hypertensive crisis and so on. So there may be other contexts where we may be using these drugs with benefit. And this is really very exciting to start thinking about this sort of changing scenario here.
So when it's too advanced and progressed already into dilating and we miss the tipping point, it's too late. Is there any way to go too early?
Well, no. In fact, if anything, we are hoping to go earlier. So, for example,
that's what I'm hoping.
Well, the grail for us would be to give it to gene carriers. So, the problem here is that this is such an unpredictable disease that you never know whether a gene carrier will ever develop the disease. So, will you spend $1 million or euros or Swiss francs to treat somebody who may never have need the drug at all? So this is where we need markers to identify the trajectories of disease in patients who have early disease, because a trial will never be really able to show a clear benefit here.
Yeah, so that's a question of non-obstructive disease as well, which is treated. Does it really matter that much? Probably yes. We don't know. So what's the next trials you're doing at the moment?
Well, right now, the non-obstructive trials are ongoing, and this is really, we're now doing a trial also. This is another concept. This is the MAPLE trial with aficamten comparing metoprolol and aficamten. And you would say, why metoprolol? Because one thing that myosin inhibitors have taught us is that we have been super using beta blockers in these patients. So we're using a lot of beta blockers in these patients, making them feel sicker sometimes, giving them chronotropic incompetence, lowering their peak VO2 consumption, and without really a benefit. So the next frontier is now to say, as soon as the patient is on MAVA or AFI, what about the beta blockers? Can it come away? Are we giving it too much? So we are now sort of in the process of really revising the use of beta blockers in these patients and try to avoid side effects and over medication, because we have done that for a long time.
I must admit, I already started some of them by reducing the beta. I have most of them on bisoprolol, and when they are on 10 milligrams and they responded well to the MAVA content, then I go to 7.5
yes,
or
very
so.
smart. That's the thing to do. Yeah.
I always tell them we will never take it away completely, probably. We don't know, but the ones on the high dosages I started to reduce a little bit.
Some patients may be very, very happy without. Some others will need some sort of heart rate slow or control of ectopics and so on. So it's a variable. But definitely we need to think about destroying an old dogma here.
Yeah.
One question, because that's the report. You think there is any role of inflammation in understanding the patient at risk, and with that, a potential for also some anti-inflammatory component?
Okay, so that is extremely challenging right now. There's definitely a role for inflammation in hypertrophic cardiomyopathy, and potentially one of the reasons we are missing the patient who dies suddenly, we're still missing them, is because we can't follow the hot phases and cold phases. We still don't know. We have attributed a lot of this to microvascular ischemia. We've done a lot of work with PET scanning, for example. But of course, inflammation is better defined in models such as Fabry disease. That is clearly a role there, well defined. In HCM, so the story needs to be written almost completely.
Because our MRI guru says there's always a lot of smoke there, which looks like there has been fire, in cardiomyopathies.
You see edema? You see edema? Yeah. Yeah.
That's what we all think. I think, and we discussed it, with the smoke plaque and in ARVC and others, right, Robert? I think they have a lot of inflammation. And when there's fibrosis, there has been fire before. And I think that plays a lot of role also in moving forward, at one point. We'll see. I think they all overlap a bit. But you know what? That's groundbreaking. And guys, please give a warm applause for that. Thank you. And I would like to Grand Dame of Hypertrophic Cardiomyopathy. Grand Dame or Princess?
So Thank you again for this great talk. And unfortunately, we are at the end of this session. We will have some meetings in the afternoon with some members of the team. Of course, if someone wants to join in spontaneously, that's always possible. And I wish you all a wonderful afternoon. Thank you.
Thank you.